At the beginning of this chapter, I already mentioned that ischemic cardiomyopathy should not really be in this chapter, simply because it's not a myocardial disease, but it's caused by coronary problems or coronary artery disease. It is the most common cause, however, of heart failure, and because it shares so many similarities with dilated cardiomyopathy, I just briefly want to discuss it here. In the end stages of ischemic heart disease, we have remodeled left ventricles, where we have diffuse hypokinesia and where it is often very difficult to distinguish from a dilated cardiomyopathy. This is a patient where you might think he has dilated cardiomyopathy, but in reality he had a very large anterolateral infarct caused by left main occlusion. You can see that the entire septum is akinetic and there's only partial or residual contractility here in the basal lateral regions of the myocardium. However, there is a difference between ischemic cardiomyopathy and dilated cardiomyopathy with respect to survival. You can see in this diagram that patients with dilated cardiomyopathy have a better prognosis than those with ischemic cardiomyopathy. Here are some other facts. Often patients have anterior infarcts simply because in general anterior infarcts are larger than inferior infarcts. We see multiple infarcts in many patients caused by multivessel disease. Remodeling is usually present, and because coronary artery disease is a disease which is present more frequently in the older population, we have older patients with ischemic cardiomyopathy opposed to dilated cardiomyopathy. Another issue to keep in mind, creatinine is also an important prognostic factor in patients with ischemic cardiomyopathy. But now let's take a look at a patient who has ischemic cardiomyopathy and what the typical features are in a demonstration.
Start with the parasternal long axis view. And as you can clearly see, the patient has significantly reduced left ventricular function. We have akinesis of the septum and residual contractile function of the posterolateral region. Let's now turn to the apical views. This is the apical view where we get very nice image quality. However, the problem we have in this view is that we are not truly at the apex and that we have some degree of foreshortening. Let's look at the two-chamber view. Again, we see the regional wall motion abnormalities at the apex and the residual contraction of the posteromedial of the inferior and basal inferior and mid-inferior segments.
Another form of cardiomyopathy is the so-called stress-induced cardiomyopathy or Takotsubo disease. Takotsubo is a container which is used in Japan to catch octopuses, and the ventricle in these patients has the typical shape of such a Takotsubo, where we have apical ballooning. The disease is also called broken heart syndrome because it is related to emotional stress and because catecholamines seem to play an important role in the pathophysiology. This is an example of such a patient, well, actually was not a patient but a relative of a patient who was in the hospital for severe illness, and while she was visiting, all of a sudden she reported of acute dyspnea, chest pain. We found ECG changes and brought the patient to the echo lab and also to the cath lab, and this is what we found. We found a patient with severely reduced left ventricular function with a typical shape of Takotsubo, where we have apical ballooning and hypercontractile basal segments of the left ventricle, and this patient also had a very large thrombus in the left ventricle. The disease is present more frequently in women than in male, and probably microspasm or coronary spasm seems to play a role. We have also seen cases where the right ventricle was involved, and the interesting thing is that very often this finding is reversible, so we have often normal left ventricular function several weeks or months after the event. Another fairly rare cause of cardiomyopathy is the so-called peripartal cardiomyopathy, which is defined as the occurrence of a dilated left ventricle and reduced left ventricular function late in pregnancy or early after delivery. The cause is not completely clear, but most likely it is related to inflammatory cytokines, and it seems to be some form of myocarditis. Probably it is an abnormal maternal immunologic response to fetal antigens. Here's an example of a patient who developed severe dyspnea during pregnancy. We found severely reduced left ventricular function and preterm delivery was performed. The patient, however, never completely recovered with respect to her left ventricular function, even though function was better at 6 months, as you see it here. What are the risk factors? Older age at pregnancy, so above 30 years, multiparity, African descent, and multiple fetuses. The disease has a fairly high mortality, which ranges between 6 and 10%, and usually if patients don't recover quickly with respect to the left ventricular function remains reduced throughout the rest of their life. Other risk factors include a history of preeclampsia, eclampsia, or postpartum hypertension. Drug abuse such as cocaine has also been reported to be associated with an increase of peripartal cardiomyopathy. I now want to turn to HIV and cardiomyopathy. Well, if we perform autopsy, we find myocardial involvement very frequently in patients with HIV infection. However, overall, the incidence of the disease varies strongly with the percentage of HIV infection in the population. For example, it will be fairly high or very high in Burkina Faso and fairly low in, for example, Western countries such as Italy. Usually we see focal myocarditis, and probably other viruses aside from the HIV virus also play a role. The disease seems to be subclinical in many patients since we only have overt cardiomyopathy in approximately 1 to 3%, and it is unclear what the effect of treatment are, specifically what the effect of highly active antiretroviral therapy really is. A very interesting form of cardiomyopathy is the so-called LV non-compaction or hypertrabeculation syndrome. As you can see in this example, we find prominent trabecula in these patients and intertrabecular recesses, and the disease is associated with other abnormalities. These range from Epstein disease to bicuspid aortic valves, aorta to left ventricular tunnel, congenitally corrected transposition of the great artery, and sometimes we also find neuromuscular disorders. This is such an example where we have hypertrabeculation of the apical portions of the left ventricle. We will find many different variations and severities of this disease. The etiology is not completely clear, but it is most likely a genetic disease, a familial disease, where we find mutations of the sarcomeric genes, for example MYH7, and we also know that many patients have subclinical forms. So if you have a patient with suspected non-compaction syndrome, you have to follow these patients, and you should also perform family screening.
So this is a patient that presented with arrhythmias, and let's take a look at her left ventricular function, which is normal. We have normal parameters with M-mode as well, and with other ways of quantifying left ventricular function. However, if we move the transducer downwards a bit, we do see that there are a lot of trabeculations here at the apex, and there's also prominent papillary muscle. We can see that also in a 4-chamber view. I'll just have to use an atypical view to show you. You can see that there are a lot of trabeculations here. And what we have here is probably a rudimentary form of a non-compaction syndrome. It's important in these patients that you really tilt the transducer in all directions so you get a good appreciation of the trabeculations, and also to follow these patients to see what the further developments are.
Now I want to turn to another infectious cause of cardiomyopathy, Chagas disease. Just a short review, it's called by Trypanosoma cruzi, which also causes megaesophagus and megacolon aside from cardiac involvement. It's a very infrequent finding in Western countries, but it's very common in Latin America, where it is transmitted by the so-called tratomine bug, and it primarily causes right heart failure, which is dominant in these patients. The typical findings are regional and global dysfunction, and very frequently will you find aneurysms, which are present in the majority of patients who have moderate to severe left ventricular dysfunction. The next form of cardiomyopathy which I want to discuss is tachycardia-mediated cardiomyopathy, which is present in patients who have prolonged tachycardia. It's probably caused by a depletion of energy stores, or maybe also because of ischemia, and it also seems to be related to the calcium channel activity and oxidative stress. Tachycardia-mediated cardiomyopathy can occur both following atrial and ventricular arrhythmias. However, it's the rapid ventricular response which causes cardiomyopathy. This is an example of a patient who had rapid atrial tachycardia due to atrial fibrillation, where we can find a reduction in left ventricular function. However, you have to be aware that in general it's very difficult to really assess left ventricular function if patients have tachycardia. This phenomenon of tachycardia-mediated cardiomyopathy is reversible. Here's an example of a patient. On the top panel you can see the patient during tachycardia, where we find a reduction in left ventricular function and also significant mitral regurgitation. 2 weeks later, after cardioversion, we can see that left ventricular function has almost returned to normal, and even mitral regurgitation has almost vanished. I also want to draw your attention to the so-called arrhythmia-mediated cardiomyopathy. This form of cardiomyopathy is caused by ectopic beats. Ectopic beats don't cause a very efficient contraction of the ventricle, because at the time of contraction, since this ectopic beat is premature, we do not have an adequate left ventricular filling yet. In addition, these ectopic beats usually cause a desynchronous form of contraction, which is also very inefficient. And if you have a lot of ectopic beats, over 17,000, this can cause cardiomyopathy. In these patients, you have to consider ablation if it is technically feasible.